Just showing you that I have nothing, no notes or anything on the wall. This is just where I'm positioning my phone. Okay, so my name is Bree Duval. This is my postpartum assessment. So before I go into the patient's room, I'm going to assess their prenatal, their birthing experience, have a good understanding of how the patient is before I go in and meet them and introduce myself. So I look at their GTPAL, the length of their labor. I would look for any risk factors for postpartum complications, their lab values. I would look at the doctor's orders for postpartum, and I would grab all of my postpartum flow sheets and assessments. Going into the patient's room, I'd wash my hands. Hi, my name is Bree Duval. I'm a second-year nursing student at St. Clair College, and today I'm going to be doing your postpartum assessment. Are you okay if we proceed? Hopefully the patient says yes, so if that's the case, I would assess when the last time they voided was. If they need to void, I would assist the patient to the bathroom, or I would help them use a bedpan if they couldn't move from the bed, or maybe they'll have a catheter in place. Once the patient's voided, I would put them in a supine position and lift the bed to a working height, drawing the curtain for privacy. I would begin my assessment of the vital signs and document those, and I would ensure I assess the fifth vital sign, which is pain. I want to make sure that the patient has an analgesic as necessary so they can participate in my assessment. Next, I'm going to assess if they had an epidural or spinal anesthesia. If that's the case, I would assess for headache, ability to move, and weight bear. I would have the patient flex their knees, put their feet flat on the bed, and lift their buttocks up. I would assess their sensation, especially in the extremities, for paresthesia, which is numbness or tingling. I would assess for bladder distension and their ability to void, as I said before. I would assess the epidural site for hematoma, redness, or drainage. Next is our bubble he, so we move on to breasts and nipples, which is the first one. You want to know if the mom is going to be breastfeeding or not. If she is breastfeeding, you come back when the baby is due to feed. You palpate that the breast is soft and filling, and you want to assess how the baby has latched. You want to see that the baby's ear, shoulder, and hip are all aligned while it's feeding. You also want to see that the baby hasn't latched onto the tip of the nipple, that it has the nipple and the areola, essentially a mouthful in their mouth. You want to see the lips are flanged, the jaw is moving, and you want to hear an audible sucking sound. When the baby's done feeding, the mom takes a clean finger, slides it along the gum line, and pops the suction that the baby's created on the breast. If the mom is wearing a bra, you can assess that it's fitting properly. You also want to teach the mom about what proper nipples are supposed to look like. So a good nipple is soft, pliable, intact, and everted. A problem nipple is when they're inverted, flat, cracked, bruised, blistered, or bleeding. If they're bleeding, the baby can have blood in their stool, and if they're cracked, we would teach the mom to apply breast milk onto the cracked nipple and let that dry. We would want to assess the mom's milk production, either with manual expression or manual or electric pumps, and we would also want to teach the mom about engorgement. That's the painful fullness of the breast. We would want the mom to treat that with either first breastfeeding on that breast or manual expression. You press down, compress, and release. If the mom isn't breastfeeding, we do not palpate the breast. We do not assess the nipple. We can assess if she's wearing a bra and that it's fitting properly. And we can also teach the mom, regardless of if she's breastfeeding or not, the use of cold cabbage leaves in the bra to relieve the soreness on the nipples. Moving on, we would assess the uterus. So you support the uterus near the symphysis pubis with your left hand, and cupping the top of the fundus using a dipping motion, you would assess for fundal height, either in centimeters or finger breadths, above or below the umbilicus, the tone, if it's firm or boggy, and the location, if it's midline or deviated. We would also assess the bladder. So when's the last time the patient voided, the amount, the color, the odor, the clarity. We would want them to have a minimum of 30 cc's voiding per hour. If the patient hasn't voided, we do toilet stimulation. If the patient still hasn't voided, then we do a bladder scanner. You can assess the height and location of the bladder using palpation and percussion to rule out urinary retention. We would also want to health teach the patient to wipe front to back and to use a squirt bottle if they don't want to use toilet paper. Next is bowel. So you want to assess for abdominal distension. Right shoulder pain is the cardinal sign for gas. Passing gas is a good thing, so we'd get the patient moving or have them lay on their left side to help pass that gas. We also want to assess for bowel sounds and when their last bowel movement was. If it's been 2 to 3 days postpartum, we'd give them Colvase or milk of magnesia to help get everything moving. While you're examining the perineum area, you also want to assess for hemorrhoids. Our next letter is L, lochia. So you would don clean gloves, and keeping in mind the amount of time that the patient's had the pad on in relation to the flow on the pad, you would assess for the amount, the color, the consistency, and the odor on that perineal pad. The consistency is very important because if there's clots, those will smush in your fingers, but if it's tissue, that won't smush in your fingers. Next is H, next is E, the episiotomy. So this is episiotomy, the perineum, the hemorrhoids, and the abdominal incision. So we group that all together. For episiotomy, we're getting the patient in the Sims position. We assess using Read-AO, and ice packs are often offered in the first 24 hours to decrease the swelling. They're usually offered or sometimes they're ordered. We also offer the patient Tux pads, which relieve and decrease the itching in the perineal area. We want to health teach the patient to be aware of signs of infection and the use of sitz baths, which is where you dip your perineum in hot or cold to increase blood flow and increase healing. Lacerations, we can have primary laceration, which is just the skin, secondary, the skin and the muscle, which is episiotomy. Third is skin, muscle, outer muscle of the anus. And the fourth is skin, muscle, mucous membrane, and the outer lining of the anus. The third one was the outer muscle of the anus. So for the episiotomy, we're assessing the laceration, the lacerations, we're assessing the laceration of the staples. We're using Read-AO. We want to teach the patient to remove the dressing in the shower and to keep and pat that area dry and clean. For hemorrhoids, we assess the number and the size of them. And for the abdominal incision, we're using Read-AO again, redness, edema, ecchymosis, drainage, approximation, and odor. And we're going to assess the dressing essentially, but you can't remove the dressing for the first 48 hours. So what you're going to do is reinforce the dressing as needed. You're going to circle any new blood spots, date, time, and sign them. Moving on is Homan sign. This is an unreliable tool we do not use anymore. So instead, we assess for edema, and we would look for the presence of it in the sacral, the peripheral, or the dependent areas, the presence of varicose veins, the risk factors for thrombophlebitis, for DVT, so that would be sedentary lifestyle or job like office or riding the plane all the time, and the use of compression stockings. If the patient has pain, redness, or heat, don't let the patient move, call the doc right away. The last one is emotion. So we want to know how the mom's doing. Is the mom sleeping? Is her quality of sleep good? Is she getting a full night's rest? How's her energy level? How's her comfort level? How is her anxiety level? How's her appetite? Is she having bonding behaviors with the baby? Does she have support systems? A general understanding of the mom. We also want to teach the mom and her support system, her partner, to be aware of postpartum depression. Postpartum depression is when that sadness, that postpartum blues carries on for longer than a week. We need everyone to be aware that this is a real thing and something to look out for. Finally, we're going to health teach based on the mom's learning needs. If anything I discussed with her she needs reassurance on, or she needs me to go over it again, I would do that at this time. I would make sure the mom has awareness of the community resources available to her and her baby. I would also make sure that the mom is understanding of the potential dangers and complications that her and her baby are at risk for, making sure that she understands what to look out for and what to do if those situations arise. That's the end of my postpartum assessment. My name is Bree Duval. My student number is 0704574, and that's it.